All right, guys, I'm Dr. Busti, your faculty and host on This Is Why, a show that helps us as healthcare professionals transform the medical knowledge that we have from what to why. Because when we know why what we do, it changes the how, and that changes everything about the patient-oriented decisions that we make every day, but only if we allow it to. This topic review is focused on evidence-based medicine and something that we all at some point, and sometimes likely more than once, experience in our careers, that dreaded moment that we realize that we should know about something and don't. That's called cognitive dissonance when that happens. What we do at that very moment makes a huge impact on a lot of things. We can have a healthy and balanced response, or sometimes we can have a negative response. Now, before I jump into the details of what cognitive resonance versus dissonance is, let's make sure that we're all on the same page. This scenario typically is centered around a question that we are usually asked of, a question that we can't answer, but probably should. Okay, so let's review 3 quick principles in evidence-based medicine to help us get oriented. First is the Venn diagram of EBM. Remember, it's the balanced, equal input of the best available evidence with our clinical experience or expertise, the integration of patient-specific factors and preferences, and when all 3 of those things come together, we then begin to implement evidence-based medicine as it was originally intended. Again, I will not stop stressing the importance and value of integrating in balance clinical expertise and the patient-specific preferences. Then you start thinking about the 5 steps, and really where this one comes in is step 1. Someone is asking a question. Again, it might be a patient asking us a question. It may be a student, resident, or fellow asking you a question, right? Or it might be you asking somebody else a question. But in any of those situations, someone is being asked a question. And depending on who that person that's receiving it, again, they might experience cognitive resonance versus dissonance, okay? All right, so let's, again, quickly review the 3rd key principle that we use a lot in evidence-based medicine, which is the type of question being asked. You guys might remember this table, which is a summary of the questions that are background questions versus foreground. And remember, as a quick summary, background questions are really kind of that basic level, broad knowledge, usually from students, residents, or people that are learning something that's new. It might even be someone like myself with over 30 years of experience, and I encounter a new drug, and I have to ask the same background question. What is the brand name of that drug? What are its indications? Straightforward information. But when we start to put it in more clinical context inside of a patient care scenario, that's when it becomes more likely to form, especially if you fill in the elements of a PICO, a foreground question, typically what more clinicians are going to care about and ask, right? So I just wanted to make sure that we're all talking about the same thing, because it's centered, this scenario is centered around, again, usually being the recipient of a question. All right. Now, what is cognitive resonance versus cognitive dissonance? You heard me refer to that. And again, I have a summary table here for you, for those of you that are listening to the audio only or on the podcast. Then you can go to This Is Why and certainly download these with one of your signing up with a free subscription. We make these available so you can use them to study, you can use them in your lectures and other things. Okay, cognitive resonance versus dissonance. So by kind of a basic definition, resonance is that this occurs when a patient-specific situation causes us to recall some information, and it's something that we already possess and it works like it's supposed to. That's where you want to be. That's where most clinicians feel like they are, right? Especially those with more experience. The downside to that is if you're overly confident or even become arrogant, you can assume that you're having resonance and in reality you're not. Okay? That's a potentially dangerous scenario. Cognitive dissonance is someone approaches you with some questions or needs some information, and you are become aware of the fact that you should know that information, but you don't have the answer. Okay? That's the scary one that we find ourselves in. That's the dreaded situation that no one wants to be in, right? So why does this matter? Okay? So cognitive resonance, well, that can increase our confidence, but remember that confidence can lead to, if unbalanced and not done in a manner that's more humble, with humility, that can often create overconfidence and make you miss things or assume that you're right when in fact you're wrong. It also reduces the stress. So why do we invest in this is why so much? Why am I doing this? Because I believe that if you know why you're doing what you're doing, you'll experience more cognitive resonance. I want you to experience cognitive resonance in balance, with humility, with the awareness that no one, and I mean no one, knows everything. I don't care how much training you've gone through. I don't care how many letters are behind your name, and I've got a lot of them behind my name. I do not know everything. In fact, the more I learn, the more I begin to realize how much I didn't know then and how much I still need to know. Okay? I think that's true of all of us, and we need to take that more humble, balanced approach so that we don't set ourselves up for failure and being arrogant, but we also don't miss things that we should see as an opportunity to build gaps in our knowledge. Because the more we build gaps and we connect the dots and we understand why we do what we do, it makes the how easier. That's why I say that. That's why I talk about that as the kind of theme of This Is Why. How is managing patients, is making clinical decisions, ordering the right thing, prescribing the right medication, dispensing the right thing for your patient, administering it the right way. That makes it easier when you understand why. Now, cognitive dissonance can evoke feelings of inadequacy. I mean, most people don't want to be there. Now, again, it could be the moment it prompts us to growth, if we handle it correctly. If we have a negative response, then it can be detrimental to us and those around us, including our patients. That's what we don't want to happen, okay? All right, so what happens, kind of going back to that scenario of, I don't think that I'm making any mistakes, I just know everything. I mean, I've taken all my tests, I'm board certified, I've arrived. That's good, yeah? I mean, I think there's an element that we all need to feel okay with that, but make sure that, again, with some degree of humility, right? So just because you have arrived doesn't necessarily mean that you know everything, right? So what happens if somebody doesn't know that they're doing something wrong? Well, that's a problem, especially if no one exposes it to them. That's why when you think about the 5 steps of EBM, remember when you apply it in step 4, the 5th A is assess. You should be assessing your own decisions, calling your patients up, doing your own retrospective analysis of your practice. Are you seeing your decisions align with the evidence? Now, what if you do know that what you're doing is not right? Well, I mean, that's bad, right? I mean, that would be the worst case scenario. Malfeasances would be bad. You're legally now in trouble, okay? So we got to keep these things in our minds, and we have to recognize in ourselves our own response. That requires some honest self-reflection, some humility, and the recognition that no one knows everything. So pulling it all together, cognitive resonance, what we know and what we need to know, we're able to apply it. We have that information. More likely to happen when we know why we're doing what we're doing, because it makes the how easier. Cognitive dissonance, we know that we don't know something, but if we accept it in a healthy way, it can create an opportunity and motivate us to learn. But again, what happens if we don't? Well, it's typically manifested by people making distractions. So what does it look like? Well, they sometimes will shame other people, right? To expose the deficiencies in other people to make their deficiency less noticeable. They'll criticize something, make it sound less important. They also create an atmosphere that's unhealthy, especially for our learners. I mean, I think we've all heard about pimping and medical rounds and being on rounds and being confronted and asked questions, and it's or being brought up to conference at the front of the class and they're just getting pelted with questions, and you're in front of your peers. You know, is that being done in a healthy way? Is it encouraging us to recognize the gaps? I mean, I'll be honest with you, I welcomed that because it was the only way I could know that I didn't know something. But what I didn't appreciate is when the person doing it had some alternative agenda, usually covering up something they didn't know. Because I did encounter that in my own training. I recognized that person actually doesn't know that, just said something wrong. Now, I wasn't in a position at that moment, being a trainee, to point that out, but I knew they were wrong, right? Because of some of the background that I had had. And so that's dangerous. We don't want that unhealthy environment where we can't ask questions and feel safe in asking that, okay? And that's why I call pimping really real-time knowledge assessment. I mean, think about that. Real-time knowledge assessment. In real time, I'm trying to assess your knowledge not to make you feel bad, but to expose a gap that we, myself with you, can fill. And when you do that, you start to solidify and connect the dots and create a foundation. That builds cognitive resonance, which is why I do it. Because let's face it, guys, I mean, the reason this stuff matters is that no one, I don't care, wants to recognize the deficiencies of themselves. I mean, that's just human nature. The other thing is, if you're the expert, the attending, you got all these board certifications, you got all these credentials, theoretically there's an extra level of weight on you, right? People look up to you, expect you to know everything. Is that realistic? No. But some element of that is true. You should know more than other people, and if not, then we do have a problem, right? But the idea there that an expert wanting to recognize, oh my gosh, I don't know something, and how on earth, why do I not know something? I mean, goodness, how did I get to this spot in my training after all that I've gone through? I should know that, right? That's hard to deal with, because when you've arrived at that point after, again, 4 years of undergrad, 4 years, depending on what you did, 2 to 4 years of training. Then some people did residencies and fellowships. I mean, some people have been out 12 plus years, me over 20. I mean, like, to go back and start over is just utterly depressing. To feel like I don't know enough, and I got to go back and read a bunch of papers because I wasn't modeled that, I wasn't taught that way, or something happened. I mean, that's just defeating. So that's why some people create maladaptive, if you will, behaviors. And historically that happens mostly with the experts because they don't want to be exposed for what we all know is probably true about all of us. So I want to kind of begin to close us with another important perspective, because this sounds, I don't know, kind of down. Sometimes it can be negative. Don't view it as negative. Cognitive dissonance is an opportunity. But I want to point out one other element of pressure. We are now in this sort of phase. I mean, EBM has been around for, like I said, over 30 years. It's well accepted. It's integrated in terminology. Guideline statements use it. The expectation is that we have evidence-based practices. Well, what does that mean or imply about the providers in a healthcare system? And I'm not just talking about physicians, I'm talking about nurses, pharmacists, respiratory therapists, all of us, physical therapists, all of us. What does that say about us? What is the assumption if we are practicing in an environment that's evidence-based? Well, that means that I should be able to articulate the evidence. I should know why I'm doing what I'm doing in some degree of context of the evidence. Now, does that mean you can quote a journal article by the volume and the page number and the exact name and who the authors are and what school that was? No, that stuff's not typically that relevant. But rather that I know, okay, I know there was a study done, maybe I know the trial name, maybe I know the basic location in the journal, like it's JAMA, New England, whatever, right? I know where to go get that detail if I need it. But I understand what that study did, and I know what the outcome was, and I know how they used that intervention. And I can articulate that to my colleagues, but I can also articulate it to the patient who might ask me that and also might expect that. Is that scenario unrealistic? Do I live in some delusional world that thinks that we could do that? I think part of the problem and the reason why we think it is unrealistic is in part because we don't see it modeled. Well, why would we don't see it modeled? We didn't train that way. It wasn't modeled for us fully that way, depending on where you trained. I had different attendings and different preceptors throughout my training who did it more than others. And when they did it, I learned more. I got more of the why. I connected the dots and I had more, what I felt like, developed cognitive resonance on how to do that thing they were talking about. So when it was modeled for me and when it was done, it wasn't as hard. It actually made things easier. The problem is at some point in the system, we have to start teaching that way, which means then the educators themselves have to know that information and then have to then disseminate it to the next generation. That's the part that's hard to overcome. So I think it's happening, and it's happening more and more over time, and there's resources available that are making that part easier. So let's not view it as unrealistic, some high in the sky thing, situation that we can never reach. We should be pursuing it because it's the right thing for our patients. And I hope, guys, that encourages you at some level, because here's the reality. We are all in the same boat, and I'm in that boat. I do not know everything. I cannot quote every study. I look things up all the time. I am not ashamed to say that. I feel like it's appropriate that we recognize this and we talk about it and we deal with it so that we can overcome these things and move on. All right, guys, I'm Dr. Busti, and this is why we're here, to invest in each other as medical professionals so that we can understand the why, develop that cognitive resonance, because it makes mastering the how easier. And that matters because when you know the evidence and its context of the why, you're not just practicing medicine, you are transforming it in an evidence-based way for your patient. All right, we'll see you next time. Take care.